we sort of, I see a lot of nodding going on. Are we comfortable there, Dustin? Where's your strategy on this?
So my strategy is actually a little bit different.
Good.
So I actually am not convinced about the superiority of Capox over Folfox. So the non-randomization really bothers me in interpreting this data this way. So when you think about if you are a primary Folfox prescriber and you're now switching to Capox for a particular patient, it's probably going to be the more active, the patient who wants to come less frequently, et cetera, probably a better performance status patient. And if you are a Capox person and now you're switching for a quarter of your patients to Folfox, there's got to be some reason why you did that. And I worry that that's because Folfox is better tolerated, that those patients have a worse performance status. And when we look at the presentations that have been made related to the IDEA collaboration, they're not diving into that particular data. It's not being presented, the performance status, Folfox versus Capox, et cetera, and a lot of the comorbidities that these patients have. So I actually am not a proponent for Capox in this setting. So I give Folfox really well. I have a lot of experience with Folfox, so I stick with Folfox.
You ever taken a pump home and tied it around your neck for 46 hours?
So
it's not easy.
Well, so the answer is yes, I have.
You have?
Because I actually had stage 3 rectal cancer.
Oh, so you have. You're the first person ever to like, psych, yes, I have. How is it?
So actually,
did it upset your cat or anything? I keep worrying about the pets at home when you bring the pump home.
Yeah, I don't have a cat, so
No,
that wasn't an issue. Didn't bother my dog either, though. So yes, it is inconvenient to bring a pump home. That's a reality of the Folfox regimen. But it's also concerning to me when you're having a patient take a couple weeks of chemotherapy pills, whether or not they're going to take all those pills. At least with the Folfox regimen, if it's gone in through the IV, I know they've had it. And a lot of the patients who didn't receive adjuvant therapy the way that I would wanted them to have were patients who were receiving capecitabine. Usually when I was doing it, it was as a monotherapy.
Great additional perspective.
So let me put a point on this. So I don't disagree, although I do disagree with the Capox data is very clear, although it has its limitations. I mean, those curves sit on top of each other, and there may be different reasons why. And perhaps, it's how you select your patients, but then that's how you need to select your patients. You can't discount Capox as perhaps a better fit for some patients. Now, that said, I don't disagree that with the higher risk patients, with the lower risk patients, I don't believe you need for more than 3 months. With the higher risk patients, I think it's fair to consider 6 months. However, I don't believe that there is much benefit from an additional 3 months of oxaliplatin for a lot of reasons. So first of all, when we look at the clinical relevance of the data, not the statistical piece, that gets quite complicated, you're really still measuring disease-free survival when we get to that point in the other abstract. Yes, it does correlate with overall survival, but you lose about half of the benefit when it translates into survival. So that one patient out of 100 that you may be hurting in the disease-free survival world, that essentially cut that by half when you get to the survival. And you're talking about close and maybe even less, 1 in 1,000 patients perhaps, who may be harmed by the 3 versus 6. Now, when you look historically at the primary driver of benefit in colon cancer, it's surgery, 50%. The other 15% that you add comes from fluoropyrimidines. And then you can argue, the data with CAPE versus 5FU gave a little edge to CAPE, but again, that was barely significant, or not significant, statistically at least. Then oxaliplatin adds about 3 to 4% on the survival, a little bit more on the disease-free survival. So frankly, and then you look at the grade 3 and 4 toxicity with your 6 months of oxaliplatin, and it's about 3 to 4% of grade 3 to 4 toxicity, which is horrendous, frankly. So it washes out. So I think an arm that was missing Was 3 months of K-Pox or FOLFOX followed by 3 months of 5-FU or
In some
capsaicin?
way, that arm was there because a lot of people stopped their ox, right? So that
Well,
really
yeah,
is
but it
that
wasn't
arm.
the intent.
It wasn't the
Yeah.
intent,
That
yeah.
wasn't the original study design. But I do want to make sure people understand that although K-Pox can be considered for your low-risk patient population for the 3 months, you still have to select out the correct patients to provide capecitabine to, right? So you need patients with good creatinine clearance. Like, I don't want people to be persuaded that all patients should go ahead and receive capecitabine. And also, I agree, adherence, we do have to follow up on in regards to adherence. But you know, there's not everyone is a perfect patient for capecitabine.
Mike, I want to sort of close this part of our discussion with a sort of shift to, you know, patient selection. You know, in metastatic disease, we're increasingly doing molecular profiling. We have these new CMS criteria for, you know, how to characterize the different cancers in the colon. And we did see one abstract which, you know, may or may not be that valuable to us today. But, you know, do you see a time when we're actually doing a better job of stratifying patients and not treating all of them the same?
Well, I think we already know that, and we didn't talk much about expression profiling, choosing patients based on that information or circulating DNA and so on. Those are potentially coming, circulating DNA metrics for who may have disease and who may not. Coming in the future. But right now, the reality is that other than MSI, and really for MSI stage 2 is where the decision comes, we're really not using that other information right now.
Yeah.
So.
I hope for it because
Yeah.
I still, you know, all this discussion about a percent here, a percent there, around 3 versus 6, we're still leaving, you know, 25% of the patients who are going to relapse and die. We're over-treating a very high proportion of patients who are cured by the surgery. So figuring this out to me is maybe the highest priority, and I'm hoping we move in that direction.